Thank you, everyone. So welcome, everyone. Welcome to our esteemed international guests, our audience from around the world. This is Sepsis Canada Network's first international event, and we hope this will be the first of many to come for our network. I'm honored to introduce our guests today, but since we have a number of individuals in the session, we would like to share a document with you that you can find in the chat. It's a brief bio of all the individuals who are going to be speaking today. I apologize to our guests that I will not do justice to them in the introduction. In no particular order, I'm going to start with Professor Konrad Reinhard, who was the founding president of Global Sepsis Alliance and a key initiator of World Sepsis Day. Professor Reinhard is a prolific researcher with almost 1,000 peer-reviewed publications. Next, we have Krista Bracke, is a patient expert and an author from Ghent, Belgium. She used to be a journalist with Belgian public broadcaster until she got sepsis in January 30th, 2009. Krista has published 2 books and developed a toolbox for patient-centered care. Then Dr. Tex Kissoon, past president of the World Federation of Pediatric Critical and Intensive Care Societies. Dr. Kissoon has numerous awards nationally and internationally, and is currently the president of Global Sepsis Alliance. Dr. Djillali Annane, professor of medicine at the University of Paris-Calais. He's an educator, civil servant who has held high-level strategic positions, serving as the chair counselor of the French Minister of Health and chair of the Health Ministry Task Force Against Sepsis. Not sure if Dr. Evangelos is here yet, but I'm going to introduce him regardless. He's a professor of internal medicine and infectious disease at the medical school of the University of Athens, has almost 500 peer-reviewed publications, and is currently the chairman of the European Sepsis Alliance. We have Simone Mancini. He is a public affairs expert with expertise in advocacy and association management. He overlooks the Global Sepsis Alliance with a focus on expanding areas in Europe, Africa, and Middle East. He plays a significant role in ensuring that global leaders in WHO, regional offices, European institutions have sepsis awareness in their agenda. And last but not least, we have Dr. Srin Murthy, clinical scientist with the BC Children's Hospital and the University of British Columbia. He has worked in numerous global multi-center clinical trials looking into COVID-19 treatments. And of course, we have Sepsis Canada's scientific director, Dr. Alison Fox-Robichaud. I'm going to pass on to her, she's going to moderate this session. If you have any questions, please ask questions in the Q&A box. And we ask everyone who is not part of the panel to mute yourself and turn your camera off. Dr. Alison.
Good evening, early morning to everyone. I have a few set questions, but I'm going to start with a little, I guess, a bit of a fact, and hoping we get some discussion. I may pick on a couple of people to start out with, and I'm so grateful to see our European colleagues here with Srin and Tex and I. You know, although it hadn't really been widely studied prior to the pandemic, we've known about post-sepsis syndrome for a while, and really about the impact on survivors around post-sepsis syndrome. We're building data now about the long-term impacts of COVID, not just for those who required hospitalization or intensive care admission, but people who had COVID and didn't require any hospital care. What is your understanding about the links between what's now be calling long COVID and post-sepsis syndrome? And maybe I'll start with Djillali.
Good morning or evening, everyone. I would say that we knew for a while that severe infections can cause long-term disorders and cognitive dysfunction. We knew it for a while. We then knew and discovered over the years that sepsis, and in particular, the critically ill one, those who were treated in an intensive care unit, may suffer after discharge from chronic problems. And that was not the focus of attention of many people. When the pandemic came in, then that changed the way people in general, the public at large, see the problem of severe infections like COVID can cause in their common life and social life and professional life, and how big the problem might be. And when in 2020, everyone thought it's going to be an acute disease and people would get sick and a few weeks after go back to their life, we now 2 years after have understood, unfortunately, is not the case. Unfortunately, there are in some people, also there is a need for clarification of what is exactly long COVID, but there are problems and people continue suffering problems long time after the acute episode. But what to me is the main lesson we have to learn from COVID-19 is that these long-term consequences are not related to the severity of the acute episode. That means that even though you have not been hospitalized for COVID, even though you have been only mildly affected at the acute phase, weeks or months later, you may have your life changed due to these long-term consequences. And then I think that for sepsis, that needs to highlight that we need also now to figure out that these long-term sequels of sepsis may not specifically occur only in those that are hospitalized in the intensive care unit. So that points out the need for identifying patients with mild sepsis, not hospitalized, not admitted to the ICU, because these people might weeks or months later have problems. So I think this is a major lesson from the COVID and the long COVID that we may translate to the management of sepsis, more generally speaking.
Konrad has some comments, and then I'm going to pick on Srin about the pediatric journey with long COVID.
So,
Konrad.
I just want to fully support what Djillali has said, and we have published, and this was in JAMA, a study that we did with 150,000 survivors from sepsis with a big insurer here. And indeed, surprisingly, also the patient with sepsis who have not been in the ICU had almost identical sequelae, and 75% of the survivors have at least one or up to 3 to 4 consequences. And clearly this, and we learn from COVID, and that's, I think, is the good side from COVID, because sepsis consequences were completely ignored and are still completely ignored, both by insurers and physicians, and physicians think that this is psychosomatic and stuff like this. And we have a lot to do to convince the whole society on this. And luckily, the discussion started that perhaps quite a number of infections like COVID. This is not so. I personally had a fatigue syndrome 10 years ago when I had a severe borreliosis, and it came again and again. So this obviously are immune reactions that need to be investigated more in detail. And and so that's a big chance now that we really convey this message. The bad news is that we just did a representative review and poll over Germany, and only less than 10% understand that COVID may, on the one hand, result in sepsis, if it's and that there is such a thing like viral sepsis, and so there are a lot of issues which come along with the lessons that we had to learn, but we must not believe that without our activities, policymakers, insurers, and physicians will understand that this is the case.
Srin, a pediatric perspective.
Yeah, of course. And so I think it illustrates a bunch of things, and specifically as it relates to kids, and we'll take long COVID as the example. What we've seen over the past couple of years is not a huge number of children becoming critically unwell with COVID-19, requiring ICUs and all the usual. But we're seeing a substantial number of children with post-infectious syndromes, i.e. long COVID, and a comparable proportion as with adults. And so it really highlights the distinction between the post-infectious syndrome and the post-critical illness specific syndrome. And so I think it highlights the idea that, oh, an infection is part of childhood, is part of growing up. We need to expose our children to these diseases and everything will be better in that context. May not be the appropriate response when we are starting to see and starting to reflect on all of the other diseases that are sort of normal diseases of childhood, and how we can sort of prevent them and be better at preventing them and possible long-term sequelae of them. And particularly in vulnerable and marginal populations who may not have the access to vaccines or access to preventive strategies accordingly. From a acute care and identification of these kids in hospitals and other things, I think it also highlights the struggles that we face in pediatric critical care as to how we say which patient should get one specific therapy or one specific care pathway escalation or what have you. And it just complicates things more broadly when you think about the long-term effects when we only think about the short term. I'll stop there.
Srin, just one for you in text, one follow-up question. Do you ever recall an infectious disease that caused this much long-term chronic problems in children? You know, aside from the kids that get sick with sepsis, that have an ICU journey, do you recall any other infectious disease? You know, RSV is common, other respiratory viruses. Do you ever recall, you know, there's something different about this virus that, you know, highlights the impact? It has more immunothrombogenic potential, maybe similar to bacterial infections.
Like, I think we're learning a lot more about new diseases all the time. And so if you think about things like EBV or CMV or other sort of viruses and their association with long-term autoimmune diseases like multiple sclerosis or what have you, I think we'll learn more as years go on about the impacts long-term of childhood infections. However, I agree that COVID-19 in terms of its spread and its burden is definitely a unique pathogen.
Yeah, I think that the one disease that popped immediately to my mind, and obviously it's probably a different sort of pathogenesis, but polio, obviously it has long-term consequences. And before the COVID issues, we thought we almost eradicated polio with a few cases here and there, I guess was Pakistan or Nigeria. But now we see polio resurfaced in New York. And I think one of the big things that we, the lessons, well, out of COVID, we realize how quickly we can produce vaccine and those things. But the downside is with the infodemic we have more people resisting vaccines, not only in the US and North America, but across the world because of the social media spread of erroneous sort of information. The other part of the issue of COVID and what it relates to long-term, especially for children, is about 70 countries discontinued their immunization programs during the last couple of years because obviously priorities were different. And there is this, the modeling have shown that there could be a burgeoning of other diseases that are sort of as a product of the policies we had in the last few years by stopping immunization programs. So outbreaks of measles, right? You see the outbreak of chickenpox, etc. That is all going to be plaguing us post this. And obviously the socioeconomic issues of poverty, malnutrition, and those things will compound all these problems across the world for children. So I think there's a lot that is going on the link of COVID, and it's so-called, I guess there's long COVID with a small L, and there's long COVID with a big L, I guess. And the societal impact of the different policies is going to affect us for a long time coming also.
Tex, you've given me the lead into my second question that I'm going to really start with Krista and Simone in terms of that. The pandemic has really been challenged by the large amount of misinformation, including from healthcare workers. And, you know, unlike previous pandemics, we've had healthcare workers on social media really ramping up misinformation. What strategies do you think we need to employ to increase sepsis health literacy, both of healthcare workers and the public, about the impact of sepsis, and including COVID-associated sepsis? Krista, start with you. You're an author.
I think
been a healthcare professional.
I think there's a lot of work which has to be done in spreading the word sepsis. We can talk a lot about consequences of sepsis and long sepsis, but the general public and very often also health professionals do not really know what it is or do not recognize it early enough. There's unfortunately a lot of people who told me that they have survived or family of them haven't survived a sepsis. So the general public doesn't have an idea what it is about. And so I was wondering, can we sort of formulate or make a sort of definition for the general public by using words which are very clear to everyone? And we might ask sepsis survivors from all over the world, try and describe what sepsis was for you, how you experienced sepsis, if you're able to talk about it, if you can experience or talk about that experience. And so I figured out maybe it's something like your body, which is completely disoriented, you're in complete agony. The moment you're still conscious that you're alive, you have the impression that you will die. You have such an enormous pain that you will die. And it's very difficult to explain it to care professionals because sometimes they can't really, they don't have the scientific results or the scientific symptoms, but you really experience, you have the feeling that you will be dead, and you're in such an enormous pain that it will never go right. And yeah, maybe it's an idea, a challenge to ask different sepsis survivors to try and explain it from their point of view what sepsis was, and why not spread that by social media?
Simone, in your role with the GSA, you know, how do we balance this? And then I'll go to Konrad after that. I want to hear your opinion as, you know, as a,
very good question, Alison. And I'm going to pick up some of the points of Christian and Krista and Konrad also mentioned before. And I think indeed, you know, involvement of survivors, we realize, you know, it's been very effective. We, you know, we try, of course, to engage mostly, you know, with policymakers, but not only with a broad range of stakeholders. And we try really to avoid not to have a survivors when we organize, you know, a discussion, a panel, etc. So that really makes it really human, makes the issue real, I find. Then the importance of data. that's a big issue that we know very well. We all know that we are lacking data, and you know, if you cannot make the case, you know, we have estimates. We have the study from Germany. We have perhaps another couple of studies, but what is the real entity of the issue? And I think if we don't, you know, if we don't calculate it, we don't assess it, we cannot really make the case for our interlocutors to pay, you know, to push them to pay attention to the issue. And we know the issue is huge. We just need to quantify it, because there are many other priorities on the agenda of policymakers, for example, and why they should pay attention to sepsis. So we need to demonstrate. We need more data, and perhaps we are, you know, there are ways we need to put in resources. We can, you know, we can work with our supporters. We can work with insurers. I'm sure we can pull the resources, because it's a big effort, nevertheless. Another so involvement, target involvement, sharing experiences, data. Yes, COVID definitely disrupted our work. We know very well. It was also an opportunity. You know, thanks to COVID, we managed to, you know, we connected, of course, sepsis and post-sepsis with long COVID and etc. And what I want to say is that, however, I'm sorry, I'm at the airport, so there's now a public announcement right now. What I want to say is that, however, there are plenty of priorities, and I think so. To your point, Alison, okay, what is the strategy? I'm out of 3 days of you know, discussions on health policies at the big seminar here in Austria, and we had a session on sepsis, and our session was, let me say, euphemistically, not the most attended. But the people who were there said, why people are not here? It was so interesting. It is so relevant. And so we need to be better in, while actually the whole program was very high level. And there are a number of issues that, you know, policymakers, for example, they need to deal with. And I think we need to be good. We need to be, you know, smart in connecting with those issues. You know, we need to connect, you know, with the discussion on, you know, support to patients, with, I don't know, with you know, equity, access to healthcare. We're talking about, you know, One Health, you know, the SDGs, etc. So there's a number of topics. I think there is a connection, and we need to be prepared to talk about it, to connect to those. And yeah, I mean, what I think there's also this sense of urgency we need to transmit. But I think there's the problem is that everybody, you know, has an urgency to propose to the decision makers, to the policy makers. And so the strategy, okay, why not also connect it beside the long COVID patients? You know, Tex mentioned, you know, other diseases, under other conditions. Do these groups, these patients, do have perhaps common issues, like sepsis survivors, for sepsis patients, for example? Can we talk? Can we have a common voice, and perhaps indeed, you know, make more noise? You know, make people understand, our interlocutor understand. Actually, it is, you know, support to patients, the follow up, etc. It's a common problem.
Konrad, I want to get you into this conversation because, you know, if we've got anybody on our side counterbalancing at a governmental level, it's the German Minister of Health. You know, they may not be able to implement policy to the best of their ability, but the G7 met recently, and, you know, we can't get consensus amongst government leaders about the best public health policies and counterbalancing medical information. You had some thoughts, Konrad?
Yeah, I am convinced that we can only make a progress when we get sepsis there, where ironically AMR is since 10 years it's on the level of WHO, of any summits in Davos, and we have an assistant director general within the WHO just for AMR, and the burden of sepsis is 10 times higher than the burden of AMR. And the difference is that so far that the issue of AMR was rightly brought up by Tony Blair from UK, so an influentially, highly influential policymakers, and that's why it's so important to get it there. And we have to continue this work. And I slightly disagree with Simone that we don't have enough data. So we have the global burden of disease report. We have 49 million cases. We know that's 11 million deaths. We know that this compares with 9.6 million deaths from cancer. But the message does not get through. We know the US Department of Health, you can find on their website that agencies like Bloomberg have already 5 years ago said America faces a 27 billion sepsis crisis, and actually it's 60 million now. So some countries have understood and have programs because the data is there. We also have the data that the majority of sepsis cases can be avoided. The Australians have demonstrated it. It was demonstrated in several countries now, including Ireland and the state of New York. So it's just, and the crucial power is really that sepsis survivors and families who lost their loved ones really reach out to the media. So this is the most effective, at least in some countries, where you get impact on the level of policymakers. So for any disease, and the cancer people have understood this in the 40s and 50s of the last century. They asked for a Manhattan Project against cancer, for a moonshot against cancer, because they said you need campaigns to transform a disease politically before you can transform it scientifically. So and the fact that we have in the meanwhile 600 only, and it is even too many still, 600,000 deaths from AIDS. We would have many more if there would have not been a great lobby and involvement of the whole society, of policymakers, and the same needs to be achieved on the other level. So this is our task. That's a strategy, and that's why. So and one question which was raised, I think, by Krista. What is sepsis? Everybody knows what cancer is. It's a cell proliferation. Everybody knows what AIDS is. It's an immune deficiency, and we should teach, and every people and in the school and parents should know that sepsis is the most severe form of infection, which is characterized by the fact that the own immune system destroys the body's own tissues. So, and we should also close and use this term also blood poisoning, because in some way it's in the minds, but we have only to overcome the notion that sepsis or blood poisoning may only derive from wounds, but must make clear that it may stem and be initiated by any infection. So this is the simple messages that needs to get across. So that's my take.
Djillali, I want to highlight your work in France. You know, you now report to the leaders of an entire country. I don't know in France whether you've had to deal with the same misinformation we have had in North America, but how do you get those policy leaders? You know, yes, data is important, but how do you get those policy leaders to realize that this disease we're talking about has not only the long-term consequences, but it probably is a bigger impact than, you know, cancer and heart disease combined.
Yeah.
And we've moved those bars.
Yeah. Well, my experience had been for 5 years as the chief counselor of Minister of Health. I've attended two G7 and G20 meetings. And what the lesson I learned from this position is that the high-level politics, they don't like something that is too vague. They want something very concrete. And I think the issue raised by Krista is the right one. For the politics, the fact that the scientists, the medical doctors, and the patients and the public at large are not understanding the same things, do not advocate the same way with the same word, and the same is for them something very reluctant. AMR was great because AMR was easy. Too much use of antibiotics equal no more effective antibiotics equal back to the prehistoric era. No one wants that. Very clear cut. Alzheimer was the same. Remember the huge global plan for Alzheimer's disease. And this was also very clear because everyone's talking the same language. That's what politicians like. And for sepsis, we haven't achieved that step. So I think it's very important that our effort, I think, should be directed toward rising or identifying words for public at large to explain themselves what sepsis is. And until we achieve this, it's going to be very hard to get the sepsis at the G7 agenda. So I think that is my experience of. In France, we could launch a number of good plans. Really, we now have embarked all the stakeholders at the French level. But when the French Minister of Health, together with the French Minister of Higher Education and Research, tried to influence at the European Commission for sepsis being identified in the research program of the European Commission, because it's about 10,000 pages. Sepsis is never mentioned on these 10,000 pages of billions of investments toward research in Europe. So
we have a similar problem in Canada.
And that illustrates how far we are from awareness from the public at large.
And that's despite advocating. I know we've got representatives from the Canadian Institute of Health Research here, but we've asked repeatedly to have a drop down for our grants that says sepsis on it, and it's still not there. I want to, next couple of minutes, but Simone and Tex, you both have some more comments, maybe just one or two lines before we move on to the last question.
Sure. Yeah, no, I think one of the things that we haven't really done a good job of is to really highlight the economic implications that sepsis steals the economic sort of wealth of a country. And I think unless we start doing that, also politicians are loath to respond to anything beyond the dollars and cents also. So we have to make a compelling economic argument, and we did some of the work here and showed that for every dollar invested was $112 in return. And I think we start most of our investigations, we need to start putting for long COVID and everything else, an economic value to things to show them it saves lives, but it also is good for the economy. I'll stop there.
Simone?
Yes.
Last comment on this.
It was exactly actually what I wanted to say, and I agree with Konrad. We do have data. I agree with Konrad that survivor story they do work. They attract attention. What we are missing is indeed the extended impact on the society of sepsis. And I very anecdotal. I was in Brussels speaking with consultancy perhaps could have some work, help us with, advocacy communication, said, okay, what's the business case? It's awful to speak in these terms, but actually, is it okay if you don't have a business? We cannot help you because we really those often money speaks, and it is a facade of the whole story, and I think that can contribute to move things.
Okay, Krista, last comment on this topic, and then I'm going to move on to the last question.
Yes, just one small comment. I'm quite sure that in Belgium, there are no data on sepsis. At least there weren't about 2 years ago when we had a roundtable for the Belgian Parliament. Very recently, one of the health professionals in cancer research, so to say, announced or answered to one of the patient experts that sepsis isn't really a problem in the Western world, certainly not with cancer patients. So we might have some work to do in the near future, don't we?
We do, indeed. So we've got our network joining. We've got patient partners from across Canada and maybe some international people joining us today. We've got our government research funding body sitting and listening today. Can each of you take an opportunity to identify one research priority for the next sort of 1 to 4 years for COVID and non-COVID post-sepsis syndrome? And I'm going to start with Srin, who's been leading a number of our Canadian studies.
I think going back to Djillali's points earlier about getting our community, and our community is broad, it's stakeholders, it's researchers, it's patients, it's everybody, to understand what we're actually trying to treat and what we're advocating for, so that we can bring those messages to our stakeholders and government for more funding and more attention. I think if we start to break things out and focus on one individual component, we may not get the attention and get the necessary funding required to move these agendas forward. And so from a research perspective, I think figuring out what exactly we're trying to research, I guess it's a vague answer, and understanding it across our community through consensus so that we all work towards the same goal.
Any other thoughts? Research priorities. Krista, from a patient's perspective, what should be the research priority in this?
I think we should invest not only in awareness, as has been told already, but also in early recognition, and in trying to find out how we can explain to the general public how also they can help in an early recognition of sepsis. Because I've learned on a symposium in France that a lot of sepsis cases already have sort of first symptoms, first signs, many days or some time before people get to a GP or to a hospital. So if the general public is aware of what might be some first symptoms of sepsis, it might help to save lives.
Konrad? You're muted.
Konrad.
Yeah. I fully agree what Krista has said, and I come back to the AIDS issue. So the incidence of AIDS has dramatically decreased. It's 3 per 100,000 cases persons in Germany, and yet still there is annually more than 10 million euros granted by the German parliament to educate on people on sexual transmitted diseases. Why is it? Because there is a lobby. And given that the incidence of sepsis in Germany is at least 450 per 100,000 persons, and we just have seen data from Sweden that is more than 700 per 100 data. So, and it does not happen because it's not known, and because there's no lobby. And Krista, just to mention, you said there is no data on Belgium. There is also data on Belgium. If you look into the supplement of the Global Burden of Sepsis report that we have published jointly with the Institute of Health Metrics and Evaluation from Seattle. So in the appendix, you will see also an estimate, which probably is an underestimate still, but there is data now, and you'll have to look it up. And we know that it's underestimated, but still there is. And when we launched the European Sepsis Alliance, we took the data from Sweden to extrapolate for Europe. And jointly with the commissioner at this time, Andriukaitis, we had this quote from him that sepsis is the #1 cause of preventable deaths and sequelae in Europe. So and there's no reason to believe that the incidence of sepsis is lower in Belgium, in Germany, than it is in Sweden. So we just need to communicate this and use all sources that we have to convince people. And of course, it's important, and we have this health economic evaluation. It has been done in UK. We have data now also for Germany, and there is data from the US. Of course, it's probably even in high income countries. So the incidence, so it's crazy, but and we will get it across just when we get more involvement by survivors. And in addition, we have now excellent data in coping with the immune response, that can dramatically, and COVID from COVID sepsis can dramatically reduce mortality. So there's also a scientific breakthrough now that it's not only about antimicrobials or antivirals. That has been published several weeks ago in Lancet Respiratory, that you can decrease the mortality rate of the most severe patient by 27% on a global scale. In the European patients population, it was 43% reduction of mortality. So this needs to be understood, and that's why it's another reason that we need that everybody understands what the difference between an uncomplicated infection and sepsis is. So again and again, the data is there. We just need to work now to convince the policymakers along this alliance, and we have to collaborate on a global scale. And Tex can confirm that we had only 2 weeks or 3 weeks ago this meeting in Germany with a great involvement now of WHO. We sense that there is a progress also on the level of WHO, and for sure also this G7 thing. And we met with WHO and the G20 partnership in Geneva only 4 weeks ago, and we will need to get also sepsis on the agenda of the G20. So this needs to be the next step. This is the only way, and we need, you know, the WHO sepsis resolution from 2017. It asks that every member state needs to integrate sepsis in the national health strategy. So the requests are there, and we need to take them by word. It does not happen, unfortunately, from alone. So it's all about lobbying and influencing, and most importantly, the survivors must play a great role.
I believe Christine Russell, and for our panelists, Christine is also a sepsis survivor, but a mother of a sepsis survivor with perinatal sepsis. So Christine, you had a comment or a question for Konrad specifically?
I did.
Well, that's what I heard. Wanted to respond to Konrad's comments.
Oh,
Maybe
no,
not.
sorry. I was answering a question in the chat. Somebody was asking about the paper that was referenced.
Okay.
Sorry. No, I don't have a question.
I believe it
Okay.
was Krista who wanted to respond. I don't
Krista
think
might
she
have
did.
wanted.
Krista.
Might have been a Chris. Might have been Krista. Yeah.
Okay. Djillali, research priorities. You've already talked about the challenges of getting it on the EU research platform.
Yeah,
Konrad's highlighted the fact that we're spending a lot of money, and I will say the same thing happens in Canada. We're spending a lot of money for a disease incidence that's going down and down and down. You know, our HIV scientists here have a standing account that's, I think, $10+ million a year, and we got 5.7 for 5 in Canada.
But I would say that as academic people, our responsibility is to really join our efforts towards getting, in the short term, an intervention that saves life. Why I'm telling this is, look at the example of stroke, and look at stroke advocacy before thrombectomy and after thrombectomy. As soon as for a disease you get an intervention that really is a game changer, then you have an extraordinary driving force to raise awareness and to attract investment and to attract attention. So I think that there are outstanding people around the world doing research in the field of sepsis. And to me, what is missing is this research is fragmented, is sealed. And we should not expect from politics, industry to unsealed. So this is our responsibility. And I think, I hope, I remember I asked about 5 or 10 years ago, and I said, hey guys, if we put together all the trials we have conducted with all the data, for sure we will get about more than 1,000 cases very well documented, most of them having biological samples for endotyping and so on. And together, we may very likely identify something that will work. And I think until we will make this step, until we will get, okay, we have demonstrated that sepsis is a reality, and sepsis is a threat that can be treated. Now we can do better, not without you. So we need the politics industry to come back to help us, but we need to do that effort. And this is our scientific community responsibility to do. That is my research priority.
I think that is a great priority. I'm going to get Saad to help us. So we have some questions from the audience. So I can't see them on the Q&A, but I think that, you know, we've been very siloed and maybe exclusive in some of the international sepsis research ongoing. And maybe this is an opportunity for some of us to come together in a format that's more inclusive about the data that's being gathered.
And that might be a lesson to learn from COVID.
Yes.
If you look at COVID, you know, that the multi-platforms, they didn't hesitate to get together and merge their data to go faster to achieve the results. And I think what was done during COVID needs to be continued after COVID for sepsis.
Okay. Saad, are you able to share 1 or 2 questions that have come from the audience?
Yeah, we have a hand raised by one of the attendees, Ilse Malfait. If you don't mind muting yourself and go ahead to ask a question.
Hello, can you hear me?
Yes, we can.
I just wanted to know where I can find the reports concerning the number of cases in Belgium. I'm a sepsis survivor. I survived sepsis 2 years ago. I lost my 2 legs and my 10 fingers. And it all started with cancer. And I want to make the government aware that there is a link also between cancer, chemotherapy, and sepsis. And the more I read about it, the more I'm, how do we say it, I'm perplexed by all the symptoms that were already there in my file from the beginning. I had fever, I had terrible pain, but they didn't saw it. I only went to ICU after 3 days. So I want to make the government in Belgium aware that there's a huge problem and that there certainly is a link between cancer and sepsis, because when you speak about cancer, everybody is listening. But when you speak about sepsis, they don't know what it is. I didn't knew it either. But so maybe with telling my story, I can help and to prevent that other people get in this situation. Sorry for my English.
Elise, it's beautiful. Thank you. I think you and Krista need to connect. And
we do already.
We do already. And we can certainly provide you with some support from Konrad, that background data to be able to advocate. Saad, is there another question from the audience?
Nope, that was it.
Just to comment to this, so we will definitely send around this report, including the supplement, because you will find the data on a country level only in the supplement. And as to this research issue, I think it's of course important that we need to learn from each other in research. However, and I have said this again, education of healthcare workers and the lay people on the early signs of sepsis works when the mortality rate from sepsis in Australia decreased from 2000 to 2012. It halved, not by speaking about sepsis, but just to implementing quality assuring issues, which means mandatory rapid response systems, which means that every healthcare worker needs to be educated on the early recognition of deteriorating patients and that there's a rapid response team. So education of public and healthcare workers is the cheapest and most effective thing. And with the same amount of money on which we educate on the spread of sexually transmitted diseases, which is important, we could save millions of lives on a global level. And it's just a question of political will and pressure.
Tex?
You're muted, Tex. You are muted, Tex.
Following up on Konrad's point, exactly where I wanted to go, is that I'm in a very rich city here for the most part, but when you think globally, the issue of education is very, very important because we don't get it right in North America. But there's a very interesting study that came out in the Lancet about 4 or 5 months ago that showed that mothers who have a college education, her kids under 5 has a 31% chance less of dying, and the fathers, the 17% chance less of dying. And there's no doubt that when we look at the Millennium Developmental Goal, not the SDG, Bangladesh, one of the poorest countries in the world, achieved the goal, right? And one of the major points that the Lancet Commission pointed out was empowerment of women. There's no doubt longer time you keep young ladies in school, they may not be poor, their children will not suffer illnesses as often, and they will seek better health care sort of for that. But the other thing in the world, I think, is across the board, is the science of delivery, implementation science. We know there are few things that work, and we have not done a good job anywhere in the world. In resource-rich countries, it's spotty how you get care, depending on where you are in Canada, US, Europe, everywhere else. And in poorer countries, the issue now is not access to hospitals, but it's very poor care when you get there that is causing more deaths. So I think that that's all have to play into it. And I think that if you ask me from one vantage point, we have to push the boundaries of science. But on the other hand, if we think of it globally, where 85% of sepsis occurs in poor countries, we need implementation science and better ways of delivering. And in our world too, the very same thing. I'll stop there.
Krista? We're coming up on the end of our session. Comment?
I'd just like to add to what Konrad has been saying, that indeed, I think education of the general public and also of care providers is extremely important. And I might suggest the idea of creating a sort of leaflets, especially for the general public, leaflets with the early warning signs of sepsis. And we might spread them anywhere, and patient organizations can play an important role in doing that. Because then the general, well, people have something very concrete to know, to be aware that, well, something might be wrong. It might be a sepsis, that they can recognize the first signs of it. So why not spreading a sort of leaflet?
You see, these exist. You find them on the website of the GSA. You find them on the website of the UK Sepsis Trust. You find them on the website of the Rory Staunton Foundation, the Sepsis Alliance in US, the Sepsis Stiftung in Germany, the Sepsis Fonden in Sweden, etc., etc. So that's, but we need to ask the policymakers, because it's like you see there were these campaigns by the CDC in the US, but this stopped. So that's why we cannot do it only ourselves, but we need really that the policymakers get serious and have this fight against any infection, and this involves vaccination against influenza, and against COVID, against Ebola, and against pneumococci. So that's a whole concept. It's about prevention. It's about early recognition. You find everything in the WHO sepsis resolution. We just need to make it happen, and it will only happen, as I said, when there is a will on the political level, and this depends. And this is a story from any other disease. And our great thing is that we can demonstrate what Sir William Osler has aired in 1900, that there is mankind has three enemies. One is war, one is famine, and one is fever. And he said, by far the greatest is fever, meaning sepsis. And this is still the case if you look on a global level on the numbers of deaths. So it's more than cancer, it's more than HIV. And also the HIV people die from sepsis. And also 1/3 of cancer people die from the complication, infectious complications / sepsis. So this is also to be published in this global burden of sepsis report. You will see that also 50% of infections and sepsis is not primary infections, but it happens in patients with chronic diseases, including cancer. So that's the facts are there. We just need to make policymakers aware of it.
Konrad, I hate to cut you off. It's just clearly evident the passion for all of this. We're now on a full hour, and we could, I imagine, keep on going. We've posted the global burden of disease, and people can look at the supplemental files related to that. I really want to thank our panelists for a vigorous discussion. It's given us within Sepsis Canada some goals. Policy is one of those. Health literacy is certainly another one that we're working on, using KT strategies to make sure that all of those pamphlets and leaflets are actually making an impact, which I'm not sure we've done a great job at necessarily measuring that, and advocating that patients and survivors, the impact of all of this on their well-being. I want to thank everybody for their time. Good evening to our colleagues in Europe, and good afternoon. And I'm hoping Srin and Tex will continue to join the scientific meeting as Sepsis Canada. Thank you so much, everyone. And for the network members, jump off of this and go back into our in-camera sessions for Sepsis Canada. Thank you, everybody.
Thank you.
Thank you. Bye-bye.